HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
In today's episode of The Clinical Takeaway, I will be speaking to Dr. David Cunnington on narcolepsy, how to identify, assess, diagnose, and manage. Dr. Cunnington, tell us about yourself.
Yes, hi. I'm a sleep physician in practice on the Sunshine Coast in Queensland, and I practice solely in sleep medicine. So whilst when I trained in respiratory and sleep medicine, as is the case in Australia with advanced training. I haven't practiced respiratory medicine for around 15 years and really focused my practice solely on sleep medicine, which enables me to have a sort of fairly broad practice within sleep medicine. So that includes insomnia and disorders of sleepiness, like we're going to talk about today.
David, the topic today is narcolepsy, which is a very single focus. Could you give us a context by which we can understand narcolepsy and then tell us about how common it is?
Yeah, it's really interesting, the use of that term narcolepsy. If you look in the Urban Dictionary, the definition of narcolepsy is sleepiness, essentially, people that are sleepy throughout the day. And often in healthcare, people are using that lay definition of narcolepsy to account for really sleepiness that can't be accounted for other reasons, for example, for lifestyle reasons. But I think it's important that we use the more medical definition of narcolepsy, which we'll get to, and think of the term hypersomnolence or excessive sleepiness as an umbrella term that covers a whole range of different disorders that can result in sleepiness. So in the International Classification of Sleep Disorders, which is the sleep equivalent of the DSM, they're called central disorders of hypersomnolence. And within central disorders of hypersomnolence, there's narcolepsy. There's another condition called idiopathic hypersomnia, where people have sleepiness and we can't find another cause. There's hypersomnia associated with medical conditions, hypersomnia associated with psychiatric disorders, hypersomnolence associated with medications. Mm-hmm. And so there are a whole range of different potential causes of hypersomnolence. And if you look at just that broader hypersomnolence in the Australian community, in primary care, boy, I don't envy you guys, because around 50% of the Australian population report being more tired than they would expect to be. So it just must be a really common thing that you're dealing with in primary care. And the challenge is to work out, well, what of those is going to have more of a sleep disorder or the sort that you might need to be referring on or thinking of one of these central disorders of hypersomnolence. And that's a much smaller subset. So if you think about narcolepsy as one of the specific sort of conditions, it's actually pretty rare. It's about 3 in 10,000. So about as common as lupus or SLE. So about that type of prevalence. If you think of the other disorders of hypersomnolence, so being sleepy associated with depression, for example, or other mental health disorders or medications or other medical conditions, it's around 1 in 10 of the population have some sleepiness that's associated with those other conditions.
So that is a marked difference, isn't it? And it's so important that we get it right, because if we say narcolepsy, we will stop thinking about how to investigate and look for the other causes. Because we're looking at narcolepsy in this particular podcast, I guess the real question is, what really is it? And how do we identify it? And how do we really be sure that we've got the right diagnosis?
Yeah, so narcolepsy itself, not to make things too complicated, but it does divide into narcolepsy with cataplexy, which is often what we think of as more classic sort of narcolepsy, or narcolepsy without cataplexy. Mm-hmm. But the narcolepsy with cataplexy, which is really the sort of prototypical narcolepsy, so people are sleepy during the day, and I'll come back to the nature of the sleepiness, but they also have other symptoms, so difficulties with the boundary between sleep and wake, so some blurring of the boundaries. So on transitioning in and out of sleep, get some sleep and wake features superimposed on each other. Mm-hmm. So dream imagery, a transient sense of paralysis, on waking up, some visual hallucinations, often associated with sleep paralysis. They're called hypnopompic hallucinations. And then the symptom of cataplexy, which is really unique to narcolepsy with cataplexy, so a very specific symptom, which is muscle weakness brought on by strong emotion. So the stereotype is someone who's laughing and falls to the ground. There are very few people get it that dramatically, but a lot of people will recognise that either laughing with friends, getting angry in an argument with a partner, they might get a bit of facial droop, slurring. They know they're feeling weak, but they might be able to hide it or mask it. But if you ask about it, they'll recognise a sort of transient partial muscle weakness with strong emotion. So that's the sort of cluster of symptoms with narcolepsy with cataplexy. And the nature of sleepiness in narcolepsy with cataplexy is usually that people actually wake up feeling okay from a nap or from a sleep, but fairly quickly feel sleepy. But that sleepiness can come on very quickly and get a sense of, I've got to sleep right here, right now. And might only sleep for a short period and then actually wake feeling okay. But an hour or two later, again, got to sleep right here, right now. And, that's really the part that has a very big impact on function, work, for example, because, we all think of work as we have to have an 8-hour period of sort of being present for work during the day. And if you can only sustain wakefulness for a couple of hours and then before you need to sleep, that really is a challenge in terms of work.
There's so many questions that come from this because, issues like safety at work and driving cars and all those things, which I hope to cover later. But I guess, what is a narcolepsy without cataplexy look like?
Yeah, so it has all those same features. So the sleepiness and the nature of the sleepiness, often the sleep boundary phenomena, but just not cataplexy. And what we think is happening slightly differently in the pathophysiology is narcolepsy with cataplexy is one of these rare sleepiness conditions that we actually know the pathophysiology. It's an acquired orexin deficiency, where someone with a particular T cell marker, which is the HLA typing that can potentially be done for narcolepsy, has that T cell marker and carries that throughout life, has some sort of triggering event that triggers an immune reaction, and that then sets off a process where you get autoimmune mediated destruction of orexin neurons in the hypothalamus. So we know very clearly that pathophysiology. So when we diagnose someone with narcolepsy with cataplexy, it's that pathophysiology, acquired orexin deficiency. Whereas narcolepsy without cataplexy, so if someone doesn't have that specific symptom of cataplexy, we don't know the pathophysiology. The spread of CSF orexin levels is a much broader spread. So the pathophysiology is a little different, but the symptomatology is the same, just without the cataplexy.
It's very unusual for me to think that narcolepsy with cataplexy is a form of autoimmune disease.
Yeah, absolutely. And that's some recent work. In the last 10 years or so, we've always understood a particular T cell marker has an association with narcolepsy with cataplexy, but that much in the same way we think about type 1 diabetes of an autoimmune trigger and destruction of islet cells, narcolepsy is that autoimmune trigger and destruction of orexin-producing neurons.
If I've got a patient sitting in front of me and I have to ask very good questions that will elicit things such as difficulty with the boundary, eliciting the boundary between sleep and wake and sleep paralysis. What are the questions that you would ask, David?
Yeah, and like everything in clinical medicine, I start broadly, trying not to be too suggestive or too specific. And so I might ask someone as you're waking up from sleep, any strange occurrences, or as you're drifting off to sleep, anything unusual that you're aware of. And then for cataplexy, it's, during periods of strong emotion, have you noticed that any muscles are weak? Doesn't have to be dropping to the ground, but just a sense of weakness. And then if people respond to that, particularly the cataplexy, I'll ask them to give me some examples, and that'll often elicit things. And interestingly, it's strong emotion, but also when someone's emotional defenses are down. So it doesn't happen in, let's say you're out giving a lecture, you've sort of got your emotional defenses up. And so it's less likely to occur. Whereas with family, or you're arguing with your partner, or laughing with friends, and emotional defenses are down, that's when cataplexy is more likely to come out.
Can you give me a question that probes the boundary between sleep and wake?
Yeah, so just as you're waking up, do you have a transient sense of visual imagery, or do you have a transient sense of paralysis or feeling as if you can't move? Now, sleep paralysis, we expect, is a self-limiting thing, rarely longer than 2 minutes. So it's something that I'm looking for. Yeah, I feel like I'm pinned to the bed. I'm aware of visual imagery. I know I'm in my bedroom, but I can just see these other things that not sure whether they're real or not.
Okay.
There's also a sense of vulnerability often at the same time.
Of being vulnerable to attacks,
Yeah, it's
fear.
it's interesting. If you look at artwork throughout millennia, it's sort of portrayed as a sinister presence just off in the background. And in Catholicism, there's the incubus and the succubus were demonic presences that would sit on the chest of people as a manifestation of sleep paralysis and hypnopompic hallucinations. So lots of cultures have that sort of, not necessarily something you can see, but just a sense of a sinister presence that's there.
Dr. Cunnington, it's amazing. Now that you said that, I can actually recall a patient describing that to me, and
Mhm.
I had no idea what was going on.
Exactly. It's very typical. There's a lovely painting by an artist called Fuseli from the late 17th century. You have a little sort of horse in this sort of sinister looking horse head just off in the shadows. And if I show patients with narcolepsy that painting, they're like, yeah, I really relate to that, even
Right.
though it's a 300-year-old painting.
Oh, wonderful.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
What will allow me to be quite sure that I've got the right diagnosis, and what do I do then?
So then really for me, the main differential when I'm thinking about someone who's sleepy and has these sleep boundary phenomenon, I'm thinking about narcolepsy, is very marked arousal. So other things that will cause these sort of issues with the sleep boundary and sleep paralysis is high sympathetic nervous system activation or high arousal. So that often goes with anxiety. I see it a bit in ADHD, other neurodiversity such as autism spectrum disorder, trauma, high levels of distress. So they're usually things we're pretty good at recognizing and have the radar on for. So that's one thing to sort of think about. So if you've elicited those symptoms, yep, absolutely be thinking narcolepsy, but just thinking, yeah, is there something else that could bring that on? And that might be something in that sort of realm. Now, if there's nothing in that sort of realm, yeah, then that's really the time to be referring them on to see a sleep physician, particularly if, because all of these things and sleep very much relates to our physical and mental health, particularly if you can't account for the symptoms because of other aspects of physical and mental health.
When I'm thinking of referring to a sleep physician, I'm aware that the patient can put himself or herself in harm's way in terms of what they do for a living, or the fact that they have to drive themselves to and back from work. And let's just say that this symptom is significant. Do I tell them to stop driving until we sort this out? What should we do in these situations?
Yeah, so then people with narcolepsy can drive. There are certain criteria that will enable them to fill the medical standards for a private vehicle license. The overarching thing is common sense.
Okay.
So if people have exercised good common sense, recognize the periods when they're more at risk, are driving short distances, not in a fatigue-sensitive occupation, not a commercial driver, then I'm not so fussed you've got to withhold them their driving before you send them to see someone. But if they're not exercising common sense, you have those sort of concerns, much in the same way as you would for other conditions, you'd advise them not to drive. Or if they've had an accident where they've not demonstrated common sense and had a fall asleep accident.
Yeah, I asked that question so that patients who end up with a problem will come back and challenge us that we were not able to give them the right sorts of caution, and they get themselves into trouble and then put us into the, if you like, the end of the responsibility. So as a sleep physician, what would you do for these patients to prove the diagnosis, and what can you do for them, David?
Yeah, so the first thing is a clinical assessment. So these aren't so much the pathway for these sort of patients isn't sort of a straight up ambulatory sleep study from primary care. The pathway is really referral for a clinical assessment with a sleep physician. So I take a history, really looking for some of the features that we talked about. If I strongly suspect narcolepsy, I will be arranging a test called a multiple sleep latency test. So that's a laboratory-based sleep evaluation that has an overnight sleep study that precedes it, and then they spend the next day in the sleep laboratory having multiple naps. And we're looking for characterising how quickly people go to sleep, what sleep stages they go through as they go to sleep, and there's some particular parameters that can help us tease out some of these disorders of hypersomnolence. Now, it's a supportive investigation rather than a very concrete, perfect investigation. We don't have a perfect biomarker. We can, in rare situations, do a lumbar puncture and look for CSF orexin levels, but in reality, we do that very rarely, just because of the practical issues with doing a lumbar puncture for people. If I suspect there's something else going on, but some of the features sort of look a bit like narcolepsy, more as a rule out type of test, I'll do the HLA typing for narcolepsy. It's not a rule in test because about 13% of the general population carry that HLA marker. But if you're in the 87% that don't carry it, it's very unlikely you've got narcolepsy with cataplexy. So for me, if symptoms are a bit atypical, I might be doing that type of test as a rule out sort of test. And then I'll be, depending on what sort of testing someone might have had before they come and see me, it'll be just making sure thyroid's okay, iron levels are okay. There's not other sort of general medical things that might be adding to tiredness. Then in terms of what I will do with them, so one is making a diagnosis. Usually these people have had symptoms for many years and they've often had multiple encounters with the healthcare system and not had a diagnosis made. And so really that's one of the key things that people find very validating is having a diagnosis made, recognising that they actually have an underlying disorder. It's not just, well, come on, pull your socks up, get on with it. Everyone else I've seen today is tired too, off you go. And so just making that diagnosis very validating. Now, unfortunately, because, I talked about narcolepsy with cataplexy being an acquired orexin deficiency, it really means it's a permanent neurological condition. And so that's got significant implications for someone. So often if they're being diagnosed and they're in their early 20s and thinking about careers and future family and things, and then you tell someone you're going to have this sleepiness thing for the rest of your life. We really need to not underplay how important that is. And, it's interesting, often when I give someone the diagnosis, that initial appointment, they're like, finally, I've got an answer. But what they don't realise is it's not going away. And the treatments so far aren't perfect. They're more supportive treatments. And so it's not a great diagnosis to have. And so that's where, in terms of then, if I'm thinking of further management, there's definitely a role for psychological support in that sort of adjustment reaction, because once people start thinking about what does the future hold and what does this mean for me, there's real implications of that type of diagnosis. In terms of other management strategies, so there's emerging work on some cognitive behaviour therapy strategies or behavioural strategies around managing narcolepsy, so scheduled napping. For example, if someone's working, I'll be liaising with their workplace to try and break their workday into chunks. So they'll have a chunk of alertness, a chunk of rest, chunk of alertness, chunk of rest, rather than work expecting them to be fully awake for long periods. So really that's that advocacy and education sort of role. And then when I'm looking at medication, it's some sort of wake promoting medication to try and extend those periods of wakefulness so that it's not intruding as much on someone's workday. Now, in Australia, the medications that we've got available are the psychostimulants. So dexamphetamine is the TGA registered medication and PBS approved sort of a medication for treatment of narcolepsy. You can use methylphenidate. It's not on the PBS for narcolepsy. And if someone has a contraindication to the psychostimulants or hasn't responded to them and meets certain parameters on their MSLT, then we can potentially apply for modafinil or armodafinil as PBS funded medication. I will also use them on a private prescription for people who might not meet those criteria, but for various reasons may prefer not to be prescribed psychostimulants. A group I think of is Victoria Police is one group, but there's lots of other occupational groups where if people are on psychostimulants, it's just a bit complicated in terms of the workplace. Whereas then a non-psychostimulant wake-promoting drug like modafinil or armodafinil might be better.
I've got a couple of questions because you mentioned that it could be young people who actually get such severe symptoms. What about the recreational things like alcohol, the use of recreational drugs, and how would you advise someone who is trying to overcome their sleepiness with very strenuous exercise?
Yeah, it's really challenging. So, again, I like that analogy with type 1 diabetes, whereas, if you think about how we try and manage people with type 1 diabetes, often in adolescence, it's really challenging because people are often wanting to push the boundary, experiment with other things in life. Narcolepsy is a bit the same. It's quite hard to manage in adolescence because to manage narcolepsy well, regular routine, not on illicit substances, not really drinking much alcohol, they're the things that lend themselves to good management of symptoms of narcolepsy. And so I'll often see someone in their adolescent years, get them through school. They may have a couple of years where their symptoms aren't great while they're at university, for example, but they'll sort of manage that by just having flexible schedules. And then by their sort of early 20s, when they've graduated and then starting to work full time, that's when they'll be a bit easier to manage because they're ready to have a more regular routine and a more structured sort of pattern. And so there's definitely phases in terms of how I go and my success in being able to manage people's narcolepsy symptoms.
So in a way, David, you're actually telling us as GPs that depending on the age and therefore the stage of life of our patients, we ought to be able at some times to be incredibly patient with them as we work through to a time when they can actually get their lives into some sort of an ordered space so we can actually work better with them. Is that what you're saying?
Absolutely. And like all chronic conditions, what I really want for people I see with narcolepsy is for them to be experts in their own self-management. Now, to develop that skill, you've got to fail, right? So you've got to get things wrong to get things right. And so rather than me being extraordinarily rigid and saying you must do all of these things, I'm really trying to take a very educative approach so that people can work out what works for them and then work out how to best manage their symptoms. Because again, it's going to be a lifelong condition. So how they're going to best manage it across life.
Are there particularly groups of people who are at higher risk?
So it does have, so narcolepsy with cataplexy does have a genetic basis that's linked partly to this HLA typing. It's not strongly inheritable. So someone with narcolepsy with cataplexy has got about a 1 in 50 chance of having an offspring with narcolepsy with cataplexy. And so that's much more common than the background prevalence in the population, but it's still not very common when we think of it as, it's not an autosomal dominant condition, for example.
Not high in men, women, younger or older people.
So no, it's across all populations. It's uncommon for it to be recognised for the first time sort of later in life. I still do see people that are being diagnosed later in life who sort of manage their symptoms across life. Much more common sort of late teens, early 20s, because symptoms then have been there some sort of mid-teens, sort of jolly through the end of school and then sort of get these couple of years and then start to work and go, well, hang on, my life's now more ordered and something's not right. I've always attributed that tiredness to, school. I couldn't control my schedule. I was really busy. Then university, I was just living life and things, for example.
Thank you for sharing with us in quite a lot of detail, something that we see, not commonly, and are always challenged in terms of diagnosis and management. So, David, I'd just like you to give us the key points of this podcast.
Yeah, thank you. So I really think one of the key ones is not all people with sleepiness or hypersomnolence that you see are going to have narcolepsy. So narcolepsy is one of the subtypes or one of the sub-disorders of the central disorders of hypersomnolence. So if you're seeing someone with sleepiness, it is really thinking very broadly about what else is going on with health that might be contributing to sleepiness. And then if you rule those other things out, then thinking, well, could it be narcolepsy, by then asking those more specific questions about the sleep boundary phenomena and the cataplexy. The other sort of key points is if someone is diagnosed with narcolepsy, is recognising it's going to have a significant burden for them and be a long-term condition for them. So, we don't need to fix it all in the first appointment, but really need to be supportive for them in the longer term. Certainly don't expect people in primary care to be experts in managing narcolepsy, but you're expert in managing chronic diseases and the sort of fallout and implications across life for chronic diseases. So that's really a skill for general practitioners that you can really leverage for people with narcolepsy.
David, I thank you for teaching us about this very interesting condition.
No problem.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.